Gives me great pleasure to introduce our next speaker. Busiku Hamainza is leading member of the National Malaria Elimination Program in Zambia. And Busiku is going to be talking to us about data for decision making, adapting lessons learned from elimination settings to high burden areas.
Thank you very much, Rick, and good morning to everybody. So just in case we don't know where Zambia is, we're located in sub-Saharan Africa. And Zambia basically is prime territory for malaria transmission because we have falciparum, 98%. Is the key parasite in Zambia, and of course we have the three vectors: Gambi, Funestus, as well as Arabiensis. I think as a country, our journey towards trying to address the malaria problem started several years ago, as early as the year 2000. We've had various national health strategic plans that have been put in place, development plans that recognize malaria as a problem for our country. And to be able to address this and mitigate the problem for malaria, Zambia has basically had 4 strategic plans over the years, focusing around initially scaling up interventions and then ensuring that whatever gains that we had made because of the scale up of these interventions were not lost. And now currently our strategic plan is focused on pushing for malaria elimination in Zambia. So transmission in the country is heterogeneous. We have endeavored to develop what we are calling an enhanced surveillance system for us to be able to understand how well or how badly we are doing in terms of pushing for malaria elimination in Zambia. So these systems were basically developed in Lusaka, the capital city, where we had noticed a decline in the disease burden, as well as additional proofs of concepts for enhanced surveillance in southern province, where we had also seen a decline with regard to malaria burden. Zambia has really benefits from very strong partnerships. And I think as I stand here, it's really to speak on behalf of the program, which encompasses quite a number of partners that we're working with. And they are distributed across the country, but have some specific geographical areas of interest. So essentially, it was really pushing what we have learned from Lusaka and what we have learned from Southern Province and try and expand that to the rest of the country where we have a higher burden of disease. So just to remind us, I think WHO has a more advanced version of this, but we basically subscribe to this ethos of the A to E approach towards malaria elimination. Really trying to focus on what we do first is really to see if we can optimize what we already have as interventions and do them well. And in tandem with that, strengthen the aspects of sensitivity and specificity for our surveillance systems for us to be able to make decisions for programming, as well as monitor how well we are moving towards that. And of course, the C and D are really focused around how we incorporate additional interventions such as parasite clearance interventions, as well as individual case investigations where the conditions allow. And of course, our target is to have a malaria-free Zambia and eliminate malaria in the country. We also subscribe to the guidance of the global technical strategy, really looking at pillar 3 to transform our malaria surveillance into a core intervention to guide how we do our programming. So essentially in Zambia, we have a health management information system that is available throughout the country. And this is reporting from a health facility level all the way up to the central level, where cases are reported with regard to malaria. We have been in the process of trying to expand what we call a malaria rapid reporting system, which is both community-based as well as health facility-based. This allows us to have weekly reporting data so that we can basically track the number of cases, as well as the use of commodities for testing and treatment at both community level as well as at health facility level. We are in the process as a ministry to expand what is being called a community-based HMIS, but that has not yet reached fruition. But as a program, we were given authority to establish a rapid reporting system which really supports the overall system with the HMIS, so that we can be able to implement our interventions better. So we've had some substantial investments in terms of, adjusting the policy, training, aspects of social behavioral change, communication. And the idea around this is to really boost testing and confirmatory rates. And currently, we have 95% confirmed cases in Zambia. So those 95% of the cases actually have a confirmatory test associated with that. And to improve in terms of the data quality aspects, we have supervision, mentorship, data reviews, data quality audits. And also to make it easy for us to be able to interpret the data that we receive, we have partnered with various institutions to establish scorecards. We have partnered with the African Leaders Malaria Alliance, and we're using their scorecard to monitor how the program is progressing. And part of that scorecard associated with that is a work plan, which we review on a monthly basis based on the data as well as the activity plans, and sort of integrate that and make decisions for programming. So this slide just basically shows you some of the dashboards that we have. This is from the Malaria Rapid Reporting System. It's got functionality to do with mapping, as well as for us to be able to see trends in terms of diseases, deaths, and so on and so forth. It is mobile-based, so community health workers as well as health facility staff are able to upload the key malaria indicators into the system, and then they are analyzed using that particular platform. In addition to that, we're trying to push for the scale-up of community health workers, trying to increase the sensitivity and specificity of our surveillance system, taking advantage of the fact that as they are able to deliver the services of diagnostics and treatment, they are also an additional reporting point, so that we can also understand better the levels of malaria transmission and identify hotspots. So the green dots that you see on the screen are the community health workers themselves, and the various colors represent some of the partners that we've been working with to advance the aspect of integrated community case management and apply also reactive case detection where it is applicable. So there are some provinces that started this much earlier than others. Case in point is Southern Province and Western Province. We have seen that over the years there's been some improvement with regards to the actual reports that we are expecting versus the expected reports from community health workers. It is still work in progress to ensure that we get 100% reporting rates. We've also seen a similar trend with regards to provinces that have been brought on board with this particular intervention. Some of them have already started reporting 100% at community level, but there's still additional support that needs to be put in place to ensure that we have our required targets of reporting from the community. So we've partnered again with Tableau, and we use that particular platform to be able to have visualizations to see how well we are doing and make decisions. This goes all the way up, is granular, where we have implemented at full scale the community health worker interventions, particularly around Southern Province and Western Province, where we have done that at full scale. The rest of the country is slowly being brought on board in that regard. And then just to share a quick visualization from Tableau, this is Southern Province. It basically shows us the incidence rates, as well as the expected reports that have been submitted and received. As at the time we took this, it was around 97%. It also shows us how many confirmed cases that we had, how many were seen by the community health workers, as well as what was seen at a health facility level. In addition to that, I'd like to draw your attention to the blue part over there, which was basically representing clinical cases. As you can see that over time, the clinical cases have severely reduced, and now we are basically getting more confident that the picture that we're seeing with regard to malaria transmission is a true one, because it's associated with a confirmatory test. With these visualizations, we get better interpretation of the data. This particular schematic here shows us the trends, but it also delineates this by age so that we can be able to have specific interventions, particularly around, I think we've heard in the conference that older children are having the burden of disease, and we are not targeting them with any deliberate interventions, and the evidence actually shows when you look at a schematic like that. So there has been some progress that has been made again. So we have what we call a harmonized national curriculum, which is basically the treatment part plus the reporting part that has been used to scale up and train community health workers in the rest of the country where we're expanding this particular intervention. We believe we've had some successful deployment, and we are now beginning to see the benefits of the additional data that is coming in. We do have discussions around whether in high transmission areas we should maintain the weekly reporting or maybe we move it to monthly. That is something that is still ongoing and still being discussed. Additionally, we use the health facility catchment areas as our unit of operation for our strategic plan. So we do annual stratification exercises just to understand where we are. And we also look at the issues of data quality and how we can operationalize the national strategic plan at the health facility catchment area level. But we take into recognizance the aspect that as we are scaling up community-based interventions, we should be cautious so that we do not skew the data in the sense that the health facility catchment areas report in the HMIS, but if the data from the community health workers is not in the HMIS, we might be having some sort of some wrong interpretations of where we are. So we are recognizant of that and seeing how we can strengthen that moving forward. So we also track in terms of activity of the community health workers as more of a supervisory tool as well, to be able to see how well they are doing their case follow-ups, for instance, how many patients they're actually seeing, and so on. So we also have additional data with regards to reporting, and this really helps us be able to understand the dynamics of the reporting system that we have in place. So as a country, we're really pushing for stratification and targeted implementation of programs. Again, just to reiterate that our unit of operation is the health facility catchment area. Right now, we're using incidence thresholds to determine the level of disease burden, and of course, using data and epidemiological information to guide our programming. So those round dots you see on the map are actually health facility catchment areas, and we use that to operationalize our strategic plan. This basically shows the levels that we have stratified the country in. So we have the lowest is level 0, where we have no transmission, and the highest is level 4. And each one of those is associated with a package of interventions that are applied at that particular health facility level. We also have what we call accelerants, and in this particular case, we use interventions such as mass drug administration to where it is applicable, where we have good vector control and we have a surveillance system in place. We apply interventions such as MDA to help us get closer to reduced burden. This is an example of a stratification that was done at provincial level. So the numbers represent health facility catchment areas in that particular level. For example, in Southern Province in 2017, there were 9 in level 0. As of 2018, that number increased to 20, and so on. So just again to reiterate the aspect that community health workers, when you deploy them, see a lot of patients. It's important to ensure that we incorporate the data that is coming in from the community health workers for us to be able to make appropriate decisions with regards to the level of disease burden that we have. So with that slide, I wish to just say thank you for your attention, and we wish to recognize Zambia's village. So these are all the partners that we've been working with from the time we started trying to push malaria down. Thank you.
Thanks very much, Busiku. We do have time for any clarifying questions. I'll just point out, maybe you might want to respond, that slide with those many partners, seems to me you need a huge management operation in the Ministry of Health in order to collaborate like that. And any comments on how hard or easy that might be?
Thank you very much, Rick. Actually, with that slide, it represents a lot of we recognize all the partners that have contributed. Some are still working with us. Others have since left our partnership, but we recognize the contribution that they've made in the past. But we in Zambia consider ourselves a program. So that is both the Ministry of Health side plus the partners that we actually work with. So we actually meet on a monthly basis at what we call our directorate department meeting, where we share and discuss all the programming with regard to all the support that we get from the various partners. We've actually put in, using the ALMA scorecard, we have a work plan where all the partners have inputted all the activities into that one work plan, and that's the one that we actually track and follow. And we discuss when we have bottlenecks, when we have successes, we pat each other on the back, and we're working together as a program.
Any other questions for Busiku? If not, thank you very much.
Thank you.